Well, this is like interesting. Click on the picture. Yeah, I think this one works. Yeah, this one I think it works.
You can just advance with that.
Yeah. Thank you. We see if they're good. Oh. If anything wants to mean to find backwards. So maybe they have to use it for a while. Oh, there's a manual used. Yeah, right. That's fine. Maybe it's not used. There's a Windows, there's a mouse button here, there's a chapter. We had a seminar in like very recently. Or oh, that was working. Okay. Windows, yeah. Windows, okay. Windows, nice of time. Okay, in the interest of time, I just want to get started with today's ISL lecture series presentation. We're very fortunate because we were spared by Hurricane Helene 2 weeks ago, and this week we're also spared by Hurricane Milton. And we definitely are very passionate, compassionate, and also about whoever got impacted by this. But I'm very happy to be able to host this event this week because it's been about 2 weeks, two months in the planning. And we're very fortunate to have Dr. George Demiris joining us today. And this morning we had a really nice event in the Tallahassee City Center with more than 40 people in the audience from our Asian community in Tallahassee, where we had a really nice discussion and conversation about the implication of technology and aging. And then this afternoon, we have this wonderful presentation by Dr. Demiris. Let me give a short brief introduction to Dr. Demiris. Dr. Demiris is a Mary Alice Bennett University professor in the School of Nursing and the Perelman School of Medicine, the Associate Dean for Research and Innovation in the School of Nursing at the University of Pennsylvania. He has been a forefront of the intersection of informatics and nursing science, and his work has introduced new and innovative approaches to all problems in gerontology. He is exploring innovative ways to utilize technology and support patients and their families in various settings, including home and hospice care. He has conducted numerous federally funded studies funded by National Institute of Health as well as National Science Foundation. His expertise is also in designing and evaluating smart home solutions for aging and in understanding the potential of wearable devices in digitally augmented residential setting to facilitate health monitoring and support independence and quality of life for community dwelling older adults. He's also a member of National Academy of Medicine and also a fellow of the American College of Medical Informatics. So today, welcome Dr. Demiris for the presentation. Please take away. Thank you.
Thank you so much. It's great to be here with you. And I'm going to talk today about artificial intelligence in aging, and more specifically focus on some examples from work that we have been doing that hopefully can highlight some of the opportunities, but also challenges and lessons learned. So, as you know, there is a lot of excitement about artificial intelligence, and even though it's been around for many, many decades, in more recent, perhaps the last 2 years or so, there's been more recognition with generative AI as to what artificial intelligence can do, specifically in healthcare. We're all anticipating a transformative leap that could actually create new models of care, could lead to early disease detection, personalized treatment plans, and even streamlining administrative processes, potentially creating models by which patients are more engaged, more empowered, more actively involved in their own care. And at the same time, as we see all those technological advances, there are concerns or perhaps reservations about how and whether AI can actually fix some of the long-standing problems we have in our healthcare system. In my own work, I focus on older adults, and all the examples I'm presenting are from gerontology, although some of the challenges we see with AI would apply, I think, to other healthcare aspects and other aspects of the lifespan. I'm going to give you an example of some of our ongoing work focusing on fall prevention. Falls are a significant issue that is at the core of a lot of gerontological research because of the implications of both the financial and emotional, physical, and other of fall events for older adults. And falls are the results of multiple vulnerabilities. More specifically, cognitive impairment is a leading risk factor. Older adults with mild cognitive impairment are much more likely to experience a fall more frequently than their cognitively intact counterparts. And similarly, housing conditions can be a risk factor. So older adults living in low-income housing with poor housing conditions have twice the risk of falling. So in this project, we wanted to specifically focus on this high-risk group, namely older adults with mild cognitive impairment, who live alone in low-income housing. And we wanted to look at a technology-mediated intervention to actually facilitate fall prevention. The goal was to use technology to see if we can create a more proactive model where we can prevent the fall from ever happening. More specifically, we're using depth sensors. So what we see on the right corner, this box gets installed into the home. There's a coach that visits the person's home, does environmental assessment, looks at fall risks in the home, such as loose racks, poor lighting, or other issues that perhaps low-cost fixes can address. Then they install this device in the living room in an area that can capture a full gauge, so several feet of a person walking. And then based on the data that they get from the device, the coach has bi-weekly sessions with the older adult where they go over specific exercise suggestions. We use a protocol called the Otago exercise protocol, which works for people with cognitive impairment and dementia. It can be tailored. There's also exercises people can do while sitting on the couch. And then they also talk about environmental adjustments and other ways to address what the data show. And the data show information about that person's fall risk over time and how that fall risk may change. Specifically, a depth sensor creates what we call silhouette extractions. So the example we see on the right is a depth sensor image. It's not exactly a video camera, so you can't identify the individual. However, it is a visual representation of what the person is doing at home. The depth sensor allows us to extract information from that, such as gait, speed, stride, length, balance, and all those parameters go into a formula that calculates that individual's fall risk score, namely the likelihood that they would experience a fall in the next 2 weeks. And more importantly, we can actually see how that may change over time. The system does use machine learning aspects, and that's where it fits under AI, because it improves its performance over time and learns to treat other people in the apartment, such as visitors or pets, as noise. And the information we get about their gait characteristics are really valuable, not only for fall prevention, but also for the coach to have a more real-time representation of what's going on with the physical aspects or the physical performance of that individual. When a fall gets recognized by the system, the coach receives a fall alert with the last 20 seconds of the fall video so that the coach can actually confirm if it's a true positive, namely the person has indeed fallen, or a false positive, something else happened, maybe they dropped a book or something else was going on. Again, I emphasize that this project is not about fall detection because this system would only capture a fall if we had a depth sensor in that room. And a lot of falls may happen in the bathroom, in the bedroom, outside the unit, and we're not capturing any of that. The fact that we might capture some falls, and we do capture falls in the living room, is only an added benefit, if you will, but really we are interested in extracting gait-related information. So in this study, that was funded by the CDC and the National Institute on Aging. We enrolled a cohort of 90 people who were community-dwelling older adults with mild cognitive impairment over the age of 65 and who lived in low-income housing. And they were recruited primarily from the Philadelphia metropolitan area. One of the findings I want to share with you that shows perhaps the promise of this or the potential of this technology is that it can actually accurately assess people's functional performance. So one of the tests that we have been using where a human expert can perform what's called the Short Physical Performance Battery or SPPB test. And actually in our study, in addition to the depth sensor, we did have the human expert go in every couple of months and had the person perform certain tasks so that they could rate their performance. For any of you who might have had that type of assessment, it's usually things like you're asked to sit down and get up and walk a certain distance, and you're being timed how fast you can do that, whether you can get up and down from the chair with or without assistance, and so forth. The SPPB test is an objective assessment of lower extremity functioning among older adults, and it has a score of 0 to 12. So the higher the scores, the better the lower extremity function. And what we found was that the way the system would, using the AI features, classify people would actually correlate highly with how the human experts would run individuals. So what that actually means is that we could use this type of passive sensing and have more continuous and accurate assessment of people's functional performance and functional overall function without having the human expert going to the person's home. And it's not that we wouldn't want the human expert to go into the person's home, it's just that in our current healthcare system, our population never had a formal gait assessment, never had that type of assessment take place regularly or even irregularly. So you can see here some examples. The person on the left is an individual with a very low score, between 1 and 2, which means that they need significant assistance in ambulation and moving around in the home. The person in the middle has a score between 3 to 4, which means that they are experiencing challenges in ambulation, but are somewhat independent. And the person on the right has a score 6 or higher, which means that they are not experiencing any challenges moving around. What the system was performing well was not only classifying people and calculating their SPP score based on the depth sensor data, but also being able to let us know when individuals shift categories. They went from the low risk to the high risk, the middle risk, or from the low risk to high risk, which is very much associated with an increase in fall risk. So if your SPPB score suddenly decreases, that also means an increase in your likelihood to experience a fall. Again, this was informative for the health coach to be able to provide specific suggestions and recommendations with the goal to ultimately, if possible, prevent the fall from happening. What we wanted to also achieve with this project was not just to have the sensor system in the home and have participants not really be sure what's being measured or why, but perhaps find a way to engage and empower older adults so that they can make use of their data and they can receive these data sets and potentially discuss them with their clinician and or their family members. So one of the challenges we had was how do you visualize gait data for different groups, including older adults and their families, so that they can make sense of the data and have actionable information. We conducted a lot of interview sessions and focus groups with different stakeholders, looking at various ways to graphically represent the gait information. Unlike blood pressure or weight or glucose levels that are somewhat more widely known or intuitively clear that high blood pressure may not be a good thing, gait speed and fall risk and stride length are parameters that are not that widely used and are not really clear to people what those numbers may mean. What does it mean if my fall risk score went up 4%? Here you see the example of the dashboard that the coach and potentially in the future a clinician would see. This is the individual, and you can see their characteristics as well as the ability to annotate the dashboard with health-related events and also know when an alert was triggered. So they can go back and study that case. It's by no means user-friendly, but at least in this case, it's our health coach who's accessing this, so they have to do all the cognitive work to interpret what they're looking at. What we were interested in is seeing how we can make that information more accessible to our participants and their families. So here you see an example of a dashboard we've been using, where again, we're trying to capture what the depth sensor are showing us. Again, this is not an example of a successful visualization, it's just an example of an attempt of visualization, and many of our participants don't really care so much for this graph. But this does emphasize the need to tailor that information and recognize that we had participants with varying degrees of health literacy, data literacy, and also different experiences with technology. We had participants who really appreciated the numeric aspects of the data and were able to track and follow all their information. Other participants who expressed the need to have this in narrative form, and rather than trying to interpret graphs, have a summary statement of, is it looking good, it's not looking good, if it's not looking good, what should I do about it? And then we also had participants who didn't want to receive any of the data and would rather have a family member or their clinician directly be informed what those graphs may mean. And here's where the role of the trusted other comes in. And we use the term here, trusted other, rather than family caregiver, because in our study, we had several participants who were very specific about wanting to have a neighbor or friend participate, but not a family member. So while most people chose, in terms of a dyadic partnership, to have a family member, we did have several participants who chose a friend, a neighbor, or other. And in many cases, we see that the information needs of the individual and their trusted other don't always fully align, as you can imagine. And especially when we think about people with mild cognitive impairment, we had cases where family members wanted more data, more monitoring, more information, more updates, and many older adults who would prefer less monitoring or less data sharing. In some cases, the trusted other was instrumental in reinforcing environmental modifications or exercise recommendations. They were part of those biweekly calls if the older adult provided consent for that. In so many cases, when there would be information that the coach would suggest, such as, I think it's time to get rid of that rug in your living room, the family member or trusted other would be instrumental in making that happen. We had also several cases where the fall alert could help people figure out why the fall happened. We had one case where a participant fell 3 times, and all 3 times it was because they had a computer chair with wheels that would not lock, and they would always try and sit backwards, which I used to do a lot, and after watching those videos, I stopped doing. And so in 3 cases, you can imagine the chair had rolled away, and so they sat on the floor. But watching that video actually jointly with their family members helped them realize the risk, and also, especially because the 3rd time was pretty serious fall, and decide to change their furniture. So the trusted other was a member of the team, if you will, that actually, in many cases, provided distinct and not always the same needs or preferences as the older adult. When it came to data sharing, again, we had different views how people wanted their data shared, if they wanted the data shared. But pretty consistently, all our participants wanted to have control over that. Namely, they should be the decision makers as to who gets to see their data, whether it's nobody, their clinician, and or family. And everybody consistently wanted feedback. Nobody, as you can imagine, was promoting a big brother model where they would say, collect the data about me, but I don't need to know what's going on. Most people wanted some type of feedback as to what does it mean that my gait changes, and how can I learn more about what the data actually show me. In addition to trusted other, many people saw their clinician as a person who should be instrumental in receiving and interpreting data. And I've already mentioned we had different participants with different levels of data literacy, namely the ability to interpret data and make sense of graphs and data representations. So we had some participants who actually were tracking their own movements with their own journal entries and comparing them to what the coach was saying, versus other people who really had very little interest or did not want to be involved in actually making sense of the data or even receiving the data. In this project, we focused on people with people in low-income housing. So as you can imagine, we had some structural challenges. First of all, in several of the communities that we were in, they didn't have broadband internet. Sometimes the housing conditions didn't allow for the depth sensor to be easily installed in the living room, whether because the person didn't have enough space or there were other issues going on. We had some people with hoarding challenges. And more importantly, we had people who had internet access because the facility that they lived in, like a retirement community, might have provided it, but they had never used it before. So they weren't even sure if or how they could get into the internet. The fact that we had several communities within the metropolitan area of Philadelphia in a somewhat urban setting that were without any broadband became more of a challenge than we anticipated. And we were able to address this by partnering with local vendors and telecommunication companies for specific packages that we could then provide internet to our study participants. But this challenge, as well as others from this study, do highlight the need for inclusivity. How can we ensure that the systems we put in place are really accessible to people? And that does call for a digital public infrastructure where we nowadays have to recognize the internet and online platforms as public utilities are accessible to all and regulated as such. I think it would be important to reflect in transparency expectations and product design for new systems, as well as in reimbursement requirements, how inclusivity has been embedded in system design. And inclusivity really is not just in terms of whether you can access the internet or you have high-speed internet, but also whether the system is designed in a way that can be easily used, whether it's for people who have cognitive limitations, functional or visual changes, and the system should be still accessible and adaptable to all. That calls for partnerships with patient advocacy groups, ensuring that future healthcare providers are prepared to advocate for accessibility of AI and other technologies in healthcare, and potentially rethink the role of patient navigators. In many systems, especially in cancer care, we have this concept of the patient navigator, who's a person who helps the patient navigate some of the paperwork and documentation challenges of transitions of care. And this could also be an opportunity to think about digital navigators that can help people navigate the more complex digital landscape. In a recent study, last year's study that was, or report, I should say, that was published by McGrattan and colleagues, they introduced the term algorithmic paternalism, namely the idea that sometimes the systems that use certain types of algorithms tend to overpower or take control of the decision-making process. More specifically, they cite studies where even experienced clinicians would second-guess their own decision-making when told that an AI system or an automated system would have a different conclusion or a different decision. And the fact that we tend to sometimes trust the algorithms perhaps more than we would trust humans. So in that paper, they talk about how to address this. We need to ensure that the patient and family wisdom are recognized and are embedded as a piece of the decision-making picture by establishing clarity around the role of power and voice in decision-making. In other words, as we automate a lot of the decision-making processes, we really shouldn't lose the patient voice, their lived experience, their needs and preferences. And that's where I think in the informatics and IT world, we talk a lot, and for many years now, about the need to engage stakeholders in all phases of system design and implementation. The fact that older adults and their families should be at the table when those systems are being designed, rather than creating those systems in silo and then trying to force them on people hoping that they will accept them. We did a study where we tried to see what's the current evidence specifically for artificial intelligence in aging, to examine the extent to which older adults may have been involved in the design, implementation, and evaluation of AI systems. So if you look at PubMed at a very quick search and look for AI in aging, you'll find about 2,000 studies that specifically would hit those two terms. And so we did a scoping review where we tried to find which of the studies actually specifically documented their stakeholder engagement. In other words, they had a substantial portion of the manuscript that described that as a methodology, rather than saying it was a system that was designed with stakeholder engagement. And only 17 studies actually were included for final review. About half of them engaged older adults during the design phase, 3 during the evaluation stage, and 2 in the implementation stage. The methods that they included were interviews, workshops based on participatory design principles, demonstration sessions, and surveys. And I think that highlights that we need, obviously, to do more in that space. Of course, that doesn't mean that only 17 projects did stakeholder engagement in AI and aging, and perhaps there were many, many more that just didn't document or didn't publish that process, but that's how they came about to design the system. But the fact that our evidence base doesn't really reflect details on stakeholder engagement, specifically for AI and aging, I think highlights the opportunity to do better and ensure more stakeholder engagement. Going back to inclusivity, I think it's important to also look at that as an evaluation criterion when we evaluate these systems. We talk a lot about digital inclusion, and now the National Institute on Aging is more formally recognizing the need to address digital inclusion, namely the ability of individuals and groups to access and use these new and innovative technologies that we generate. And that also means we have to think about access. How does the community or an individual have the right infrastructure to be able to access, to harness the potential of these technologies? Then look at long-term adoption. What are facilitators and barriers to purposefully use technology independent of whether access is available? And how applicable is the technology? All those principles that address specific purpose areas where thoughtful development of technology could benefit community well-being. So we have been using a framework for evaluating a lot of our technologies as we design them that look at those parameters, namely the accessibility aspect, the relevance, and the impact. When we think about accessibility, we need to consider all these parameters that have to do with the availability of resources. For example, if we're thinking about a passive sensing system, do we have the necessary infrastructure, whether it's internet, the hardware that needs to be used, or the software application that comes along? We need to address issues of affordability and sustainability. And again, this is a critical aspect in the gerontology space, because we might have a great system that people can learn to depend on for their safety, but then maybe later down the road they can't afford it, or the system doesn't become sustainable anymore for them. We need to think about perceivability, and that really speaks to whether people can actually interact with the system, recognizing their own abilities, whether it's vision, hearing, or other, whether they can operate the system, and whether they can understand what the system means or what the output is. And this has to do a lot with literacy, as we mentioned before, numeracy and graph literacy. Relevance has to do with the purpose and the meaning of the technology. In other words, does this system actually serve an actual purpose that people feel meets their own needs? And here we have obviously multiple stakeholder groups. And then does the system align or is congruent with personal, cultural, or institutional values? And then finally, what is the impact of the technology? Is it a direct benefit on the users and or other stakeholders? And is the system safe to use, or does it introduce unintended consequences? I think when we think about inclusive design, it is important to understand that this is not just in order to try and include more users for the sake of being inclusive. But in a recent report of the National Academies of Science, Engineering, and Medicine, they actually did provide significant evidence from studies that show that trying to be inclusive is not only a social and ethical imperative, but also an economic one. And actually, many vendors who had inclusivity as a mandate in their design and reaching out to larger groups of people because their systems were more accessible, had actually also more financial gains. And that we can We don't need to think of a dichotomy of a system that's only difficult to access for some and therefore high profit, but rather think about the financial benefits coming from inclusivity. And in that same report, they also talk about intergenerational justice, namely how decisions made today will affect future generations. And that plays a role when we think about artificial intelligence for screening, for predicting which populations may respond in a certain way, or deciding who might get treatment or what type of treatment they may get based on predictive analytics that use AI components. Again, I think it's important to recognize that the systems we create have to be considered, designed, and also evaluated in the context, both the societal, clinical, and ethical context in which they're introduced. And so recognizing all those parameters calls for a more broad evaluation. Another example I wanted to mention from our work has to do with an initiative we have at Penn that specifically looks at AI and aging, that's funded by the National Institute on Aging, called Penn AI Tech, or Penn Artificial Intelligence and Technology Collaboratory for Healthy Aging, which is quite a long term. But basically, it's an initiative funded by the National Institute on Aging to accelerate the design and evaluation of innovative technologies that will improve lives of older Americans and their families. It's basically, this collaboratory is looking at technology across the whole spectrum of the different sites, namely starting with the home, collecting data in the home, all the way to the clinical site to facilitate clinical decision support. And those data sets can come from various data sources and at different sites, but ultimately as a person transitions through all those different settings, their data could be used in a way that can actually enhance quality of life and care outcomes for that person. So Penn AI Tech provides a national pilot competition program. Each year we fund 10 to 15 pilot projects. In years 1 and 2, we've awarded a total of 4.4 million, and year 3 competition is ongoing. Basically, we are accepting applications from industry, academia, and health systems. And each applicant sends their application through a portal for review. The application gets reviewed within the collaboratory and then by NIA. There's 3 collaboratories right now funded by NIA that all 3 together are called the A2 Collective. One is the one at Penn I mentioned, Penn AI Tech, and then there's one at Johns Hopkins, and one, it's a partnership between University of Massachusetts and Harvard called the MASS AITC. So innovators, researchers who are doing work in aging and technology can apply and choose one of those 3 collaboratories to send their pilot application. The pilot application is up to $200K in direct costs for 1 year. The program has 2 tracks, what they call healthy aging and ADRD for Alzheimer's disease and related dementias. So an applicant who is using technology, let's say, to improve quality of life of older adults with diabetes would apply to healthy aging, meaning non-ADRD specific, and then people who are looking at solutions or diagnostic tools for people with Alzheimer's disease and their families would go into the ADRD track. The goal, as I mentioned, is to fund new technologies that have the promise of impact and could be high risk, but also high return. NIA specifically calls for applications also from entities that wouldn't otherwise apply to NIH because of the long waiting times and how the regular funding cycles could actually lead to delays where a lot of startup companies may not be that interested in that. And when the sites get selected for funding, they receive mentoring from each of those collaboratories. So the collaboratory has an aging core, an ADRD core, a stakeholder engagement core, a networking and mentoring core, technology selection, clinical validation, stakeholder engagement. So the core leads work with these awardees to help them with their project needs, whether it is to validate their project with specific groups of patients, to get technical assistance, to help them with recruitment, as well with ethical issues. Penn AI Tech has an ethics core that consults all our awardees with ethical issues. And those are not just issues around informed consent or how to write their IRB application. In some cases, they're really complex ethical issues that provide case studies for further discussion, especially around dementia care. As you can imagine, we have cases where technologies are designed for people with dementia, where the decision whether people should participate or not is often made by somebody who's their power of attorney, who is their family member. So you end up in situations where perhaps the family member trying to keep their loved one safe consents to something that perhaps that individual may or may not have necessarily appreciated. And so how do you deal with that decisional conflict when you're trying to balance the need to keep people safe in their own home with trying to preserve their autonomy or what their wishes would have been? As I mentioned, it's a national cross-sector competition. Here's some statistics from all three centers in terms of our applications. In terms of locations, in the last 3 years, we have received applications from all states except from Idaho and Arizona. So, I'm sorry, not Arizona, Arkansas. So if you have friends in these two states, please encourage them to apply immediately, because we want this map to be completely, I guess, orange, or it looks red on your screen. And when you look at the sites that apply, we have a mixture of academia, for-profit, and other. And one could say, well, what are other? Usually other are health systems. We got some of the larger health systems that do have research groups apply as well. But some projects are a partnership between academia and industry. And we also have some that partner with health systems too. So the triangle where all three circles meet are usually those projects that tend to have involvement from all three entities. When it comes to the areas that we are funding, the projects that we've funded so far from the three cohorts have to do with technology around cognition. Namely, can we use different technological innovations to assess somebody's cognitive abilities or predict cognitive decline? It's very popular with a lot of startups to find ways to predict if somebody is experiencing cognitive decline based on the way they talk, based on the way they type, based on the way they pick up the phone. Some of these applications are really scary to read, because if all that proves right, then every aspect of our daily living could become a predictor for cognitive decline. We had an application that said that, you know, they're tracking how you're typing on your computer, and they can predict when the cognitive decline happens. So I'm thinking, just imagine if our employers found that as a useful tool, and then one day you're coming to check your email and you get a notification that we just realized that you really should be out. So there's a lot around, can we predict cognitive decline? Then there's things to help people with mobility issues, activities of daily living, accessibility and availability of resources, decision support, treatment and management of care, and many others. There has been clearly a shift in the last year with the rise of generative AI and the more awareness about what those tools can do. We saw a significant increase in applications that provided mental health support, so chatbots, virtual companions, and looking at ChatGPT types of applications specifically for aging. More than 3/4 of our funded pilots involve machine learning, and more than half are developing user-facing software. In terms of the technologies, these vary. We have a lot of applications that involve wearables, environmental sensors, smart home devices. The idea here is that the projects need to have a deliverable. So NIA does not want to see theoretical work where you're proposing a concept for a system that could potentially be designed in the future, but rather you have to have a system that's either working or is a better prototype, and ideally you would deploy it in some capacity in real-world solutions. The goal is to have an impact, and how NIA defines impact for these applications is that this project would lead to either adoption in the real world, somehow maybe health systems would purchase that technology, or it would be freely available, and or a business plan that would show that this becomes commercially available and viable in the market. In terms of the clinical themes, what the technologies are being used, I already mentioned the trends that we have seen in the last 3 years. But as I mentioned, we do see a shift. The first cohort was mostly about diagnostic assistance, and they chose the keywords personalized medicine, remote monitoring, and telemedicine. Then patient risk identification, administrative workflow assistance, and then more recently, this has been a category that was much more represented this year was mental health support. And again, these things were identified based on the keywords that the applicants themselves choose. So what we see in this collaboratory is a way to promote innovation for aging. And I think what NIA is trying to facilitate with this type of infrastructure is the need for partnerships between industry and academia. And I think that is key, given the rapid advancements that industry is experiencing with artificial intelligence. Academia in many cases is behind. So these partnerships are needed if we want to accelerate that type of innovation. We're talking earlier today about how Nobel prizes are now going to people in industry, which would have been perhaps in the past considered a place where you don't do academic research. So, but now we realize that especially in the AI space, industry has in many cases more rapid advancements. So working in silos was never a good idea, but especially when we think about technology and aging, that's a definite area where interprofessional, interdisciplinary collaboration is essential, both in terms of clinical specialties being at the table, social sciences, psychology, psychiatry, medicine, nursing, social work, but also different types of engineering, computer science, and many more. One of the things that also this collaborator is trying to promote is to include financial considerations. So they do encourage applicants to partner also with business schools or some type of health economists who could also provide more insight into how that system in the future could be financially sustainable. We've seen so far artificial intelligence is a promising tool, but at the same time we have all these parameters that we need to ensure it's ethical and transparent and efficient use. We've seen AI being used as a tool to supplement services for existing healthcare processes, namely using AI, let's say, to automate or summarize clinical notes, or to improve some administrative processes, let's say scheduling. AI to address workforce shortages or cost issues and replace aspects of in-person care. We start to see that in our applications, in some cases where systems are proposed for mental health check-ins with a chatbot. So instead of having the social worker or somebody else call, you have a ChatGPT-like assistant who checks in regularly on the person, whether it's to assess if they're lonely or if overall they're doing well. We see examples of AI that introduces new types of services that were not previously available. I think the example of Sense for Safety that I mentioned earlier could be an example of that. We have screening and fall prevention services that we wouldn't otherwise have available, especially for this population that does not have access to like a fall clinic or specialized gait assessment. And then we see examples where AI is being used to engage patients and families outside of clinical care settings, where, for example, chatbots are used to provide assistance, to interpret things, but not out of a service that's coming out of the hospital, but really a consumer-facing application. Many people feel that one of the great potentials of generative AI is the fact that you can tailor the content. You know how you could go to ChatGPT and say, please explain this as if I were 5 years old, or please explain this as if I didn't speak English as a first language. The fact that you can tailor the output and customize it could potentially be quite beneficial when it comes to disseminating health information, because you could translate things immediately, but also change the reading level, for different audiences with different literacy levels. And people have already started using generative AI to redefine the consenting process. Right now, when we consent people, especially with an electronic consent form in research studies, we don't really know if they're fully getting what they're signing up for, but we're hoping through dialogue to get at that. But if they're doing it on their own, it's hard to assess that. So generative AI can actually provide us with opportunities to generate consenting templates that are customizable in real time based on the individual's responses without hopefully changing the content or the messaging when it comes to what risks and benefits are being communicated, but rather making that more accessible. So obviously there's a lot of opportunities to support existing models of care as well as create new models of care through AI. I close with a quote from Weizenbaum, who was the creator of ELIZA, one of the first interactive computer automated systems that talked about most of the damage that the computer could potentially cause depends less on what the computer actually can or cannot do than on the qualities that the public attributes to the computer. I think it's a similar case with artificial intelligence. We have perhaps a certain hype and excitement and anticipation as to what AI is going to do in healthcare, and more specifically for aging. At the same time, AI alone perhaps is not sufficient to address some of the systemic issues that we're facing in healthcare when we talk about all these studies that show how, let's say, generative AI models in some cases perpetuate biases, whether it's racial or even gender and ageist biases because of the quality of input data. So similarly, in other instances, I can think of AI being a tool that doesn't necessarily address those issues, but rather exacerbates them if we don't design the systems in a way that calls for more inclusive design, more transparent and accountable design. So I do want to conclude with some enthusiasm, reserved enthusiasm for the great potential that AI might be introducing in gerontology. And with that, I want to thank you for your attention and happy to answer any questions.
Thank you very much. Very interesting. So pragmatic question, but to collaboratory. Failed to give us a sense of the funding rates for the
Yes. You failed or showed, no, I'm kidding. I will disclose. So, but we have seen a growth in the application numbers from the first year. Our most recent year 3 cohort, we received 87 applications that were specific to pain, and we are funding 10. So 10 out of 87. The other 2 collaborators have received about the same number. I think UMass received 70 and Hopkins received 90. And they're also funding, because we all fund the same number each year, or the same amount, I should say. They fund 9 to 10 each year.
These are 1 year, 200K seed grants.
Yes.
And is there an advantage to teaming with technology-based companies? You sort of alluded to that. That's sort of one of the things you guys are looking for.
Sometimes there is an advantage because the application requires for a plan for sustainability and commercialization. And academics sometimes are not as good at that, although we've had plenty of applicants who were just academic applicants and did really well. And NIA defines that broadly, so it's not so much commercialization in the sense of, you know, what's your business model and how are you going to start making money out of it. In some cases, they also call for just making sure it translates into the real world. So if you choose to give it out for free, it's still a plan for sustainability. But that, I think, could in some cases be a benefit of having an industry partner. On the other hand, industry partners sometimes struggle more with institutional review board language, human subjects, recruitment. So we see that oftentimes those partnerships tend to have both of those areas well addressed because they have expertise in each.
Oh, thank you. That was very exciting. One of the things that really caught me was stakeholder sort of engagement in the whole pipeline. So if you look at the stakeholder perspective of the healthcare industry as we knew it. So I was just wondering, what your thoughts are towards, how that stakeholder perspective needs to be brought in as we think about, how AI should integrate with healthcare and what the future may entail, looking at how the healthcare infrastructure is built and what it will be.
Yeah, I think that's a really great question. The challenge sometimes with these solutions is that they don't take into consideration the workflow implications and also issues around liability or accountability when generating new data. So we often will see solutions that say, hey, with this new technology, we're generating much more data about how you're moving around in your home or what you're eating, what you're drinking. And somebody's going to look at that data. And the implication is that would be a clinician who would somehow be looking at new data sets. When in reality, as you know, our system is not one where a primary care provider could actually even have the time to look at that data, not to mention the legal and other implications of having patient-generated data in the electronic medical record. So I think just like sometimes system designers fail to capture the older adult's voice, they also in some instances fail to capture the health system perspective, not only in terms of what technologies they might see as beneficial, but how would they practically use them. We talk a lot with clinicians who complain about patients who bring printouts of their Fitbit data. And the goal here is the person tries to be engaged and say, look how great I'm doing. On the other hand, the clinician just doesn't have the time or the bandwidth. And in some cases, there's not even a structure to embed those data into decision-making because there are either new types of data or data that we were not able to capture before. If we leave aside the question, how valid are the data if you use a consumer technology that may or may not have been approved? Even if we were assumed that all the data were accurate, still there are instances where telling our doctors, let's say, my sleep time decreased by 3%, or my activity level went up by 2%. That's not part of the standard decision-making process where they could say, okay, then I guess I'm going to prescribe X, Y, and Z. A lot of this is information that helps look at long-term patterns, but are not necessarily clinically actionable, at least in the moment. So I think just like we are designing things in silo without inclusion of older adults, the same applies to health systems, which is why I think health systems should have a say in this. Obviously, sometimes there are competing interests. Health systems obviously think about revenue from a different perspective than, let's say, a company that wants to go direct to consumer. But the health system needs to be reflected in those discussions and in those designs.
I have a question about ethics. You mentioned that in your AI center in UPenn, you do have an ethics forum where you help investigators for doing this type of technological intervention or ethical review process. I wonder, in the age of generative AI, if people are kind of proposing some intervention, they're supposed to be using things like ChatGPT or Gen AI to generate content for patients, for them to make decisions for the healthcare. How would investigators navigate these challenges of convincing IRB that this is safe to do?
Yeah.
In a phase that there's actually no there's a lot of uncertainty in terms of what actually have been generated and provided. So do you have any guidance about that kind of process?
Yeah, I think what we are experiencing at my institution is somewhat of a strange situation because the IRB has decided when it comes to generative AI to leave it to each school to determine the policy. So your research project will have a different life cycle depending on what school is submitting the proposal. So for example, medicine and nursing have taken a very strict approach whereby you cannot use ChatGPT that doesn't have a local, that's not the local storage, but rather you upload data, cannot be used for any research purposes. Whereas the Annenberg School of Communication allows it. So it is a little bit strange because it doesn't necessarily, it's not a decision driven by the risks and benefits, but rather by the stand that each school takes to minimize liability. I think that's a moving landscape. What we found with our applicants is that oftentimes we'll have industry partners who say, I need to get EHR data or this clinical information uploaded to ChatGPT, and then that's a non-starter for our IRB. So even the idea itself cannot be pursued. It's not even possible for us to say, let's figure out a compromise. That changes, I think, ultimately in our system, they will have to come up with a campus-wide approach, because right now, to me, it's kind of strange that investigators between different schools talk about their experiences, and everybody has a different experience based on what school they applied. They send their application from. I actually would be interested to see how here at FSU you deal with generative AI approaches. I think our IRB perhaps was overwhelmed and decided to decentralize and say every school figure it out themselves.
Yeah, FSU, I think my experience with our lecturing projects is that we have to work with Microsoft to come up with a BAA plan to utilize their OpenAI implementation within our Microsoft Azure HIPAA compliant environment. So it's something complex I'm still trying to figure out. So we're going to have a lot of meeting with our partners to figure out exactly how we can deal with this compliance. Question?
I really like your part about cognitive decline using AI like that. I was wondering if you have any favorite reward examples where you see AI being successfully used to detect early cognitive decline, especially in elderly populations, that we can kind of use as a framework moving forward for detecting early onset things like Alzheimer's.
Yeah, I think there's a lot of really interesting work out of many, both industry and research sites that deal at detecting cognitive decline as it's manifested in different aspects. So I know in the smart home literature, motion sensors, for example, are being used to show sometimes how your activity of daily living changes, and there's less regularity in your patterns, like you start to walk around at night or you miss appointments. There's also some work that looks at assessing cognitive decline through communication. So they use motivational interviewing, where you're basically having a friendly call and you're asking somebody how they've been, what they've done, and you're trying to extract features that could allude to cognitive decline, whether it's through repetitive questioning or some other aspects. I think and I know there's a lot of groups that are trying to look also at some of the standardized cognitive assessments that we do in the clinic, and whether we could convert this to some type of AI-enabled assessment where you don't have the clinician, but it's kind of embedded in a small talk conversation or some type of a chatbot tool. I think there's a lot of examples. The only concern I would have with those systems is whether they've been tested in a variety of settings and circumstances, because sometimes the performance of those tools that have a diagnostic component is very different when you do it in a research study in a laboratory setting or in a very carefully monitored setting versus in a plethora of housing conditions, living arrangements, and so I don't know that we have yet reliable and extensively validated tools, but I know there's so much work in that space. I wouldn't be surprised in a few years there would be significant, pool of commercially available solutions.
That discussion it relates to what I was thinking about. Is based on your talk, it showed a lot of great examples, at least in my opinion, of how you could integrate AI to achieve positive health outcomes and devise interventions that improve the health of people and communities. We also have examples in the real world of bad examples of implementing AI. So, for example, United Healthcare recently got in trouble because they created an algorithm to evaluate claims, and it falsely rejected 90% of the claims it denied. Or there is another example of a private company who tried to, like you had said, diagnose a certain condition. Turns out it was only predicting medication that is meant to treat said condition.
Mm-hmm.
So based on that discussion, what is your opinion on what makes for a good use of AI in intervention versus a currently bad use of AI?
Yeah, that is a great question. I'm not sure what the answer is. I do think that we have to, especially when we think about AI for diagnosis or screening or prediction, what is the utility of the information that the system is supposed to generate? Sometimes it can serve billing or financial purposes, but it's not clinically relevant. Sometimes it is clinically relevant, but there's not much you can do So I'll give you an example. Sometimes we ask questions to collect the data, but we are not necessarily doing anything with that. So is it worth collecting the data or diagnosing something that we cannot address? I'm sure in your systems probably too, but in Pennsylvania, a lot of the social determinants of health questions have been now embedded into primary care. So you go to your primary care doctor and they ask questions like, do you have food insecurity? Do you feel like you can't pay the bills? Do you feel alone? Do you feel lonely? And if you say, yes, I do have food insecurity and I do feel lonely, they'll say, okay, well, here's a phone number for social support, good luck. And so it has increased documentation burden, but not necessarily improved any specific outcomes, or I don't think yet that we have evidence for that. So similarly, when you think about AI diagnosing certain things, if something is not immediately actionable, I wonder if it is useful. Even when they say, your typing patterns on your computer are saying that you are experiencing some cognitive decline. Is there an immediate action plan to that? Then I would say, okay, that's useful information. If it's just FYI, that's probably not that useful. And when you have those types of systems that have this FYI component, you can always be assured there's a third party that will make use of it. And whether it's for a good purpose or not, it remains to be seen. So I think bad AI systems obviously are the ones that perform poorly and introduce risk and are dangerous or can harm patients, but are also the systems that even if they perform well, generate information that's not actionable or meaningful to people, or can be used against you. I always worry when they say, oh, your employer wants you to be well, so they're going to put this wearable on you and they can track every moment where you are. Some of those technologies, when they have such a huge amount of data that they process, can be used for good or bad.
Yes, thank you, Dr. Demiris, very appreciate your great presentation. So I have two specific questions. The first one is within your slides, so you show the SPPB slide cutoff point. So I'm wondering if you apply any kind of AI machine learning to capture people's behavior, the activities of daily living. So how we can capture their behavior in the room. And the second question is, you mentioned that the people with mild cognitive impairment or early stage Alzheimer's disease, so they may have some reversible issues. For example, they have some difficulty with finding the correct words, or they have like some language problems. So is there any specific neural network model can help us to detect people's reversible issues? So,
yeah, both great questions. So for the first one, I do think that, and we don't in our study look at the SPPB scores in relation to other data. So we can only say the system is good at discriminating those classifications. But this is an excellent point. You could use that information to also see what else is going on in the home, and do those changes correlate to SPPB's changes? So for example, if you were to use motion sensors or other sensors in the home in addition to the depth sensor, you could potentially explore, does an overall increase in sedentary behavior and maybe more isolation or lack of interactions result from a change in physical functioning, which one would assume it probably does. But yes, absolutely, there would be, I think, really great questions to better understand what an SPPB change means for your daily living. And it should be relatively easy to capture if you have some additional technologies along with the depth sensor, or even self-report, which we don't even do that. We don't go back and ask, have you seen any changes? Because this grant was specifically focusing on the diagnostic performance, but I think it opens up a lot of very interesting research questions. And in terms of your second question, our group has not done any work with language patterns and communications, but I know there's a lot of groups that are trying to look at different types of AI tools for that. I think there's a group out of one of the UC systems, maybe UC Davis, that is looking at engaging people in conversation and then trying to extract from just regular everyday conversation things like word finding or other challenges that people experience in their language, So I think that there are many groups working on that. I don't know how far they've come with it or how reliable or stable the systems are, but yes, there's clearly huge potential there.
So I think in the interest of time, we'll just close our session here. Let's thank our presenter, Dr. And we prepare a very special recognition for you to join us today. So I want you to give this gift,
Oh, thank you.
and I hope you will not feel it's too heavy for your luggage. Yeah, she's much happier. So we actually have some light food and snacks outside as reception, so please feel free to do that. And also engage in our more conversation with Dr. And we're looking forward to seeing you other events with once ISL in the future. Thank you. Yes, great. So much.
Thank you. Should I end the meeting?
Yeah.